speaker here again. I love this event, and it's such a great opportunity to share research that we're doing with health influencers, with chefs, with cooks, with writers. So this is really a great opportunity. And so, as Darlene mentioned, I'm going to be talking about plant-based diets for human and planetary health. So we're switching gears a little bit from the demonstration this morning. Let's see. So just a brief overview of my talk this morning. I'm going to start off by sharing some global trends of obesity, diabetes, and related chronic diseases. And then I'm going to focus on dietary risk factors for these conditions, but with an emphasis on plant-based foods, such as peanuts. And then I'm going to talk about the role of diet in environmental sustainability and introduce the Sustainable Development Goals in case you haven't heard of these before, because I think they're important in sort of guiding where much of our research is going. So in recent decades, the world has seen an unprecedented rise in the prevalence of obesity. And in fact, rates doubled since the 1980s. And in 2008, it was the first time that the world had more people who were overweight than underweight. And so I want to show, I keep looking this way. I'm used to talks where I have this thing here, so I have this. See yeah. So here I wanted to share some prevalence data with you about the rise in obesity over time. And so just to orient everybody, when I say obesity, that refers to having a body mass index greater than or equal to 30. And body mass index is calculated by height in meters over kilograms over height in meters squared. And so, so we can see the prevalence in 1980 in blue and 2008 in red, and it's separated by women and men. And you can see pretty much across all parts of the world, there's been an increase in obesity from 1980 to 2008. And in 1980, so there was about just under 8% of women were obese, and then that pretty much doubled in 2008. And then similarly for men, prevalence tends to be lower in men, but you can see a similar magnitude of increase of doubling rates between 1980 and 2008. So that was some older data, so I wanted to share some more updated data with you. So that's what these maps are showing. They're showing prevalence of obesity worldwide. On the top, you have men in panel A, women in panel B, and then the bottom two panels are showing trends in boys and girls. And so the point of this graphic is that obesity is not just a problem in adults, it's also a growing problem in children globally, and that has huge implications for public health because we know that obesity is a major risk factor for developing diabetes, and then diabetes is a major risk factor for a number of chronic health conditions such as heart disease and stroke, kidney disease, eye disease, and nerve disease. It's one of the leading, it is the leading reason for amputation worldwide, for example. So this is really called a pipeline of disease. And so, as I mentioned, obesity and diabetes tend to travel together. And so what this is showing you is that over time, so since the 1980s to 2014, you can see a steady rise in the prevalence of obesity over time in all parts of the world. So low-income countries, lower middle-income countries, high-income countries, the world. So you can see that. And this is showing diet. So this is now showing current diabetes prevalence, and you can see the U.S. there with rates between 9 and you can see them with between 9 and 12, with greater than 12%. And the U.S. was once upon a time considered the epicenter of diabetes, but this is now really a global issue, and you can see other parts of the world also in that deeper shade of purple. For example, the Middle East, North Africa. So prevalence is really starting to creep up. So in the US, just to give you a number to orient you, the number of people living with diabetes in the States is about 30 million. And for people with diabetes and pre-diabetes, it's at about 100 million. So this is a large population who suffers from this condition. And as you can imagine, this is expensive. So what this graph is showing, this is from the International Diabetes Federation. It's showing diabetes-related healthcare expenditures in 2015. And you can see countries with the darkest shade of purple spent over $5 billion in healthcare expenditures related to diabetes in 2015. So this is an expensive condition. Countries in Africa, you can see, have less healthcare expenditures, but that's not because diabetes isn't a problem. It's just because there isn't the resources to devote to managing the increasing risk of diabetes in those regions. Many of these regions also will suffer from concurrent conditions of undernutrition and infectious disease. So you might have heard the term a dual burden or double burden of disease, and so what that's referring to is the fact that a low or middle income country is experiencing concurrent problems of undernutrition or malnutrition, infectious diseases, but also obesity and related chronic diseases. And so this is showing the top 10 causes of death and associated risk factors in the US in 2013. And just to show you, in men and women, the number one cause of mortality is heart disease. And you can see the list. There's related conditions such as diabetes, cerebral vascular disease such as stroke. But what I want to draw your attention to, so the next figure that popped up, it's showing the associated risk factors. And dietary risk is the number one risk factor for all of these conditions. So that's really important to think about, because diet is something that is modifiable. It's something that we can work on to change and to improve, to address these risk factors. So the relationship between diet and chronic disease or cardiovascular disease is not a new concept. Does anyone know who this person is on the cover of the Time magazine from 1961? That's right, it's Ancel Keys. And so this is sort of the person who really, his work led to the development of the Mediterranean diet. So what he was a physician in Minnesota in the 50s, when he realized that the number one, the population with the greatest heart disease in Minnesota were wealthy businessmen. And he was like, that's kind of strange, that's not what you would expect. And so he started trying to dig deeper into this question, and one of the ways he did this was launching something called the 7-country study, which is a prospective cohort study of a number of different countries around the world. And what he found was countries that consumed the greatest number of calories from saturated fat also had the greatest incidence of heart disease and heart disease mortality. And so in sort of delving into this, what he came to discover was that countries were eating, the saturated fat was coming largely from animal-based diets, and countries that had lower saturated fat were the Mediterranean countries that are consuming more plant-based diet. And so decades following that, we saw a lot of evidence coming out to support an adverse relationship between saturated fat and heart disease. So there's been a number of studies that have looked at that, but not all studies are created equal. So I wanted to just spend a moment talking a little bit about study design, because it's really important to understand that not all studies are created equal, and that some studies are better able to answer questions related to diet and chronic disease risk. And so, the first 3 study designs on this list, so ecologic studies, cross-sectional studies, and case control studies, These studies tend to be not the best options when we're looking at the relationship between diet and health outcomes. Ecologic studies study relationships on a country level, so they're sort of looking at, per capita intake of a certain exposure and, the prevalence of disease of that in the same population, but there's no way of linking the individual who's consuming that particular exposure with the outcome. Cross-sectional studies also, they take a snapshot of time, so they ask an individual, what are you eating? Do you have the disease? There's not this essence of temporality, and when we're trying to look at the relationship between diet and disease, we want to have a temporality. We want to follow this over time. That's the key issue, which is why a lot of our work is based on cohort studies, where we follow groups of people over time and look at the development of the disease in terms of risk factors, etc. And then the gold standard, the typical gold standard is randomized controlled trials. And so that's when you have one group of people who are randomized to one diet, and then you have another group of people who are randomized to a comparison diet, and then you study them over time. And that's considered the gold standard because when you randomize people, you sort of balance out risk factors. You wouldn't expect to have more smokers, for example, in one group or the other group if they were truly randomized. So what that's doing is it's getting rid of this issue of confounding, which is something in the cohort studies, the observational studies, we worry about when we're interpreting results. And so that's why randomized controlled trials are considered the gold standard. But the tricky thing with trials is that it's not always feasible to do a trial when you're looking at the relationship between diet and a chronic disease like diabetes or cancer, because that would take years, it would take decades of follow-up, and it's not conceivable to do a trial of that duration. It would be expensive. Participants just wouldn't comply. I mean, that's just not, it's not a feasible design. So that's why we do prospective cohort studies when we're looking at long-term relationships. And then I wanted to throw out meta-analysis. That's something that you might have heard of, you might have come across when you're looking at the research. And what that is, it's a statistical approach where results from a number of different studies are combined to give you an overall average of all of the evidence on a given topic. And why this is important is because more and more policies are being based on meta-analysis. For example, the dietary guidelines for Americans are based exclusively on meta-analyses, so it's important to sort of acknowledge that they're out there, and to also for researchers to be able to do them well and to be able to identify meta-analyses out there that haven't been done well. So I'm going to also now talk, because a lot of the research that I'm going to be sharing with you is based on the 3 Harvard cohort studies. I wanted to just talk a little bit about them. And Julia mentioned these a little bit in her talk yesterday when she was sharing some of the work that we've done. But just to give you some greater detail about these studies, we have 3. The Nurses' Health Study, which is a large cohort of female registered nurses from 11 U.S. states. So 121,700 to be precise, who were aged 30 to 55 at baseline at the study start in 1976. And diet is collected every 4 years using a food frequency questionnaire. And then information on medical conditions and lifestyle is collected every 2 years. And these cohorts are very well characterized. There's bloods have been collected, genetics, toenails, hair samples, fecal samples for microbiome analysis, etc. And so the Nurses' Health Study 2 is a similar cohort in terms of structure, but it's slightly younger nurses at baseline, so they were aged 25 to 42 years at study start in 1989. And then the Health Professionals Follow-Up Study is a similar design, but male health professionals from across the US, and they were aged 40 to 75 years at study start in 1986. And for all of these cohorts, food frequency questionnaires are administered every 4 years. They're self-report. The participants fill them out, mail them back, and then likewise for the biannual questionnaires that ask about lifestyle and medical history. And so medical diagnoses are then confirmed with a medical record review, so they're validated. The self-reports are validated. So highly validated cohorts with a lot of rich data and information. So a study that was conducted a few years ago, and this is a study that I think is, I still love this study, even though it was published many years ago. This was done by Dariush Mozaffarian, who's now the dean at Tufts University. And so what this study was looking at was the relationship between changes in food and beverage consumption and weight change. And this was, he looked at this question every 4 years over 20 to 30 years of follow-up in the 3 cohorts. And what he found was, you can see on that graph, the leading dietary factors linked to the greatest weight gain over time was potato chips, potatoes or fries, processed meats, butter, sweets, refined grains. And then you can see the food items where the bars are going in the other direction. Those dietary factors were associated with less weight gain. Notice I didn't say weight loss. This is looking at weight gain. And so the average person gains about a pound a year over time from middle-aged. And so what we're interested in looking at are dietary factors that lead to less weight gain. And so we can see this list: vegetables, nuts, whole grains, fruits, and yogurts. And then for the beverages, of course, sugar-sweetened beverages, fruit juice jump out, and then we see the other beverages on the other side, milk and diet soda. What I want to draw your attention to on this graph, of course, is the red and processed meat, the processed meat and unprocessed red meat, and of course the nuts. And so that's this graph is now showing global meat consumption. Of course, we know that the Western world is really where a lot of the meat consumption is happening. You can see per capita meat consumption in 2012 in the US was among the highest, between 100 to 130 kilograms. And so, but the point I want to make here with this graph is it's really low and middle income countries now where meat intake is starting to rise. And that's a concern for a number of reasons. And this graph probably shows it a little more clearly. And so this is looking at meat consumption per capita in 2010 to 2012, and then projection to 2022 in Brazil, Russia, South Africa, India, and China. And you can see in all of these areas, meat intake is on the rise. And why does that matter? Well, based on studies that have been done in our cohorts as well as other cohorts, red and processed meat has been linked to increased diabetes, increased coronary heart disease, increased stroke, increase of certain cancers. And I want to mention that in 2015, the World Health Organization... Oh, thank you, Darlene. I should have asked everybody to bring their arrows, yes. The World Health Organization actually classified processed meat as a carcinogen and red meat as a probable carcinogen. So the fact that meats are on the rise in low and middle income countries is a concern. And then red and processed meat has also been linked to total mortality. So now, so we know that red and processed meat is bad for a number of chronic health conditions. So what we've done in a lot of our studies, and we talked a little bit about that yesterday in Julia's talk, where we do substitution analyses. So this is so a substitution analysis is where we mathematically model what would happen if you replace 1 serving per day of red or processed meat in your diet with 1 serving per day of a healthier option. And so that's what we did here in relation to risk of developing type 2 diabetes, where we mathematically modeled what would happen if you replaced 1 serving per day of red meat with other foods. for example, nuts, low-fat dairy, whole grains, poultry, fish, etc. And what we found was that there was a reduced risk of diabetes. So for nuts, there was about almost a 23% reduced risk for diabetes, just for swapping out 1 serving per day of red meat. We did a similar mathematical modeling for heart disease. What would happen if you replaced 1 serving per day of red meat with 1 serving per day of other protein sources? And we found, yes, we found decreased risk of coronary heart disease when we replaced red meat with poultry. Good news for our demonstration this morning. Red meat for fish, red meat for nuts, and red meat for beans. We're looking at between a 20 to 40% benefit, reduced risk of coronary heart disease. And so we did a similar substitution analysis with respect to total mortality. And again, these substitution analyses that I'm talking about were done in the Harvard cohorts. And so this is looking at what would happen if you replaced red meat with other sources of protein, nuts, legumes, whole grains, etc. And what we found was that there was, again, big surprise, a reduced risk of total mortality. For nuts, almost a 20% reduced risk for total mortality. And so this is now, this is results from a meta-analysis that's looked at the relationship between nut consumption and risk of diabetes in panels A and B, cardiovascular disease in panels C, and mortality in panel D. And I just wanted to, so this was a meta-analysis, so that's what I had mentioned, where a number of studies are combined to give you sort of an overall average assessment of risk. And what panel A is showing you is that those who consumed the greatest amount of nuts had the lowest risk of diabetes. You can see nuts were about 6 servings per week. Diabetes risk almost came down to about 16% reduced risk. And then this is pooling a number of studies. And what panel B is showing you is when they adjusted for BMI, so when they removed the effect of BMI from this association, the relationship, the association was flat. And what that's saying is the relationship between the benefit of nuts on diabetes is largely through improvements in body weight, so BMI. That's what that's showing you there. And then in panel C, we're seeing a benefit of consuming more nuts with reducing risk of cardiovascular disease. So consuming about six servings of nuts per week brought cardiovascular disease down about 30%. And then for mortality, about six servings of nuts per week brought total mortality down to about 15%. And again, this is now why this is important is it's not just based on our data. This is looking at sort of the evidence out there, the evidence base. And so now this is an older study that we did that looked at the relationship with nuts and risk of diabetes in the nurses' health study. But even though it's looking at nuts, it was really peanuts, because at this time in the cohorts, the nut consumption was primarily peanuts. And what we found was that consuming nuts 5 or more times per week was associated with 30% reduced risk of diabetes. And again, I shouldn't say nuts, I should say peanuts, because that's really what was being consumed at this time in the cohort. And then we also looked at peanut butter. And so what this is saying, consuming 1 tablespoon of peanut butter 5 or more times per week compared to those who never consumed it or consumed it less than twice, or basically never consumed it, was a 20% reduced risk of diabetes from peanut butter, 1 tablespoon, just 5 times a week. And so this is, now Julia talked a little bit about this study, and so she showed the main effect results from it, but this is the substitution analysis where we looked at, this was the study she was talking about, the plant protein versus animal protein. In that same study, we also looked at food sources of protein. So that's what this is showing you. This is now looking at substitution of peanuts and peanut butter for animal protein foods, refined grains, potatoes, etc. So when you replace these foods, 1 serving per day of dairy, refined grains, poultry, eggs, red meat, fish, potatoes, and processed meat, there's a reduced risk of diabetes. So for example, processed meat, when you replace 1 serving per day of processed meat with 1 serving per day of peanuts or peanut butter, there's about a 20% reduced risk of diabetes. And then for potatoes, for example, there's about a 15% reduced risk of diabetes. And Julia also talked about this study. This was a study that we recently published that looked at total cardiovascular disease, which is heart disease and stroke, and then looked at heart disease and stroke separately in the 3 cohorts and pooled results from the 3 cohorts so you can get an overall average from the 3 cohorts by nut type as well as peanut butter. And so if we look in the column of the pooled results, we can see that peanut butter doesn't really jump out as being beneficial, but peanuts do. And so I wanted to pause here a little bit. So one of the challenges in observational research is teasing out confounding. And so when we say confounding, that's this phenomenon where your exposure, so for example, peanut butter, is related to another factor. For example, white bread, if you're having your peanut butter on white bread every day, and that white bread might be related to your outcome of interest. This is confounding. And there's statistical things that we do to try to get rid of that confounding, where we can adjust for these factors, like adjust for white bread, and try to remove that, but it's really tough. And that's kind of why people say randomized controlled trials are the gold standard, because this issue of confounding doesn't exist. Because when you randomize people into your groups, those other factors balance out. There's no reason that one group would eat white bread, for example, more than the other group. That's balanced out, and that's why. And so, so with respect to the peanuts and peanut butter in our cohort, it's tough because peanuts might be consumed, like I said, with white bread. Maybe they're consumed in candies. So it's a little bit tough to really tease that apart. So when we're trying to look at the relationship for something like peanuts or individual foods like that, a trial can be really helpful. And we actually just finished a trial in China, where we compared snack peanuts consumed twice a day to a refined white rice snack bar, and looked at biomarkers, so development of risk factors for cardiovascular disease. And the results are being analyzed right now, but things are looking promising. And we were able to do this study with support from the Peanut Institute and the National Peanut Board, so we're really, really happy about that. And so perhaps next year we'll have results to share about that trial. And so we also looked at different types of nuts and risk of mortality in our cohort. So this is looking at all-cause mortality, cancer mortality, and heart disease mortality by nut type. So any nut, peanut, and tree nut. And what we found was that if you look, so this is again in the nurses, which is the women, the health professionals, which is the men, and then the column that's pooled, that's the 2 cohorts pooled together. And so you can see so risk of death among study participants who consumed nuts 2 or more times per week. So just twice, 2 or more times per week, versus those who never consumed nuts. There was, just under a 20% reduced risk of, a 12% reduced risk of all-cause mortality related to peanuts. So consuming peanuts reduced risk of total mortality by about 12%. And so just 2 or more times per week. And then if you look at heart disease, and you can see peanuts reduced consuming peanuts 2 or more times per week compared to those who never consumed peanuts, reduced heart disease mortality by about 25%. And so, so that was in our cohorts, and then Julia also shared the results from this study that I also think is very important. This was done in 3 other cohorts. So it was done in 2 cohorts in Shanghai, a cohort of men and a cohort of women, and then in a cohort of US and lower income populations. Also found a benefit of consuming peanuts on total and cardiovascular disease mortality. So it's not something that's just specific that's happening in our cohorts. This was replicated in other cohorts around the world. And so I just sort of wanted to share that. And what's so important is that, you know, this benefit can be achieved with peanuts, and which we know they're not very expensive. So this is really great news for these populations. And so how do peanuts and other nuts confer these health benefits? And so I'm not going to go into elaborate metabolism right now or biochemical pathways, but I want to make the point that peanuts really do contain a number of beneficial components. They're rich in dietary fiber, they're rich in plant-based proteins, they're rich in healthy fats, they have a number of micronutrients, phytochemicals. I highlighted arginine here. It's an amino acid that's rich in peanuts, and we're very interested in looking at how that might be conferring benefits specific to peanuts over that of other nuts. And so nuts and peanuts really are a holistic food that has a number of health benefits through these properties. And so we saw that, you know, what I showed you, that, you know, we know consuming red and processed meat is unhealthy, it increases risk for chronic disease. We saw that replacing red and processed meat with healthy sources of protein, such as nuts and peanuts, which are plant-based, are beneficial. But what is a plant-based diet? Does that mean a plant-based diet? Do you have to be a vegetarian to have a plant-based diet? These, you know, this is kind of a new concept, and so there isn't really an accepted universal definition of what it means to have a plant-based diet. So that kind of makes it difficult to translate this into recommendations, and it's difficult to study. Vegetarianism isn't very prevalent, and we're not going to really go out and tell the population to become vegetarian. And also, not all plant-based foods are healthy anyway. So these are some questions that we're sort of looking at. And one approach that we've recently approached this question with is coming up with a graded approach to study plant-based diets. So this is a spectrum, right? So people eat a variety of foods. So now we're looking at it as a spectrum. You know, what is the proportion of plant-based foods in your diet relative to animal foods? And then, well, what are the proportion of healthy plant-based foods? So we're able to look at it that way. And so just to show you what I mean, I'll walk you through this. This is all done in our cohort. So this is an example of the food groups from our food frequency questionnaires. And the top panel is showing you the plant food groups that are healthy: whole grains, fruits, vegetables, nuts, legumes, vegetable oils, tea, and coffee. And then under that you have the less healthy plant food groups, which are fruit juices, refined grains, potatoes, sugar-sweetened beverages, sweets, and desserts. And then there's the animal food groups, which is animal fat, dairy, egg, meat or seafood, fish, and miscellaneous animal-based products. And so my colleague did this analysis, and so what she's looking at is the relationship between plant-based diets and looking at animal foods, less healthy plant-based foods, and then healthy plant-based foods. So the healthy plant-based foods are in the yellow dotted line, animal foods in the red line, and then less healthy plant-based foods in the dashed blue line. And this is being looked at in relationship for risk of heart disease. And so what you can see is that yellow line is going down. So what's that showing you is that healthy plant-based foods were associated with lower risk of heart disease, whereas the animal foods and the less healthy plant foods were associated with greater risk of heart disease. And then this is now the indices. So this is looking at that sort of that spectrum. So people who had, so the unhealthy plant-based foods are in the dashed gray line. Plant-based, just all plant-based, not differentiating what's healthy or what's unhealthy, is in the blue dotted line. So that's all plant-based foods. Healthy plant-based foods now is in that orange line. So it's showing, it's beneath the plant-based foods. So what that's showing you is that the healthy plant-based foods reduce risk for heart disease more than all the plant-based foods combined. And then up at the top there, you see the unhealthy plant-based foods increasing risk of heart disease. So this is really important when we're talking about plant-based diet. Well, they're not all created the same. We have healthy plant-based foods and we have unhealthy plant-based foods. And I think this is really important for us to keep in mind when we're talking to the public about switching to a more plant-based diet. And so we know that the dietary guidelines come out every 5 years, so now things are getting going for the 2020 iteration, right? And so the Dietary Guidelines Advisory Committee for the 2015 Dietary Guidelines really promoted consuming more of a healthy plant-based diet for reducing risk of chronic diseases. But they also made a point of consuming the same healthy diet, plant-based diet, for environmental sustainability. And that part of the Dietary Guidelines Advisory Committee's recommendations did not make it into the actual dietary guidelines. So just to orient everybody, the way the dietary guidelines work is that a scientific advisory committee comes together. It goes over the evidence on different dietary factors and health outcomes, puts together their recommendations, that goes to Congress, and then you have your dietary guidelines come out. And so what is recommended by the advisory committee doesn't always make it through Congress. And well, the component on plant-based diets and planetary health did not make it through Congress. So it didn't end up in the dietary guidelines for 2015, but maybe we'll see it in 2020. But I think the fact that it was on the agenda of the advisory committee is really interesting, and it kind of shows the direction that some of the nutrition research is going in. And so with this graph, and so why? Why would they include this component on planetary health in the dietary guidelines? Well, one reason is because of this concern of climate change. This is showing how much the monthly temperatures have increased over time, and that climate change is happening. And so to try to mitigate some of the potential impact of climate change, various scientific communities are trying to come up with strategies. And one strategy is reducing consumption of animal products. And so this graph is showing the relationship between different types of food and environmental sustainability. So it's looking at, it's showing that animal-based foods such as pork, eggs, fish, poultry, dairy, and beef are harder on the environment in terms of land use. They use more fresh water, so that they have higher resource use of fresh water, and they also produce more greenhouse gas emissions compared to plant-based foods such as wheat, rice, maize, roots and tubers, and pulses. And so I tried to get information on this on peanuts. It wasn't it wasn't as straightforward as I thought. And in fact, I borrowed, this is where I borrowed some information from the Peanut Institute's publications, and this was something that Darlene actually sent, from publication that Darlene had sent me. And so this is comparing greenhouse gas emissions from various food, oops, I did have a graphic that was supposed to pop up, but maybe it didn't. It was showing peanut butter, there was going to be a circle around peanut butter and nuts there that are showing, comparing to some of the animal products such as lamb and beef. You can see peanut butter and nuts have a quite lower impact in terms of greenhouse gas emissions. And so this is a graphic I also took from the Peanut Institute, and I really like this. I thought this was kind of an interesting or an informative way to talk about how just switching from consuming processed meats or meats to peanut butter can impact or improve water use. And so what this is saying, compared to a hamburger, a peanut butter and sandwich could save 3.5 pounds of carbon dioxide emissions, about 280 gallons of water, and 12 to 50 square feet of land from deforestation or overgrazing. And on there, the little graphic, it says the water it takes to produce the beef on one burger could produce peanuts for about 17 peanut butter and jelly sandwiches, and the land that it takes to produce that beef could produce peanuts for 19 peanut butter and jam sandwiches. And hopefully those peanut butter and jam sandwiches are on whole wheat bread. And so another graphic I took from the Peanut Institute was a comparison of other nuts, because not all nuts have the same impact on environmental sustainability. Some nuts are more sustainable than others. And so this is showing water use, and we can see peanuts, the water use for peanuts is much lower than that of walnuts, almonds, or pistachios. Peanuts also have nitrogen fixation benefits, which is something beneficial for the plant, the soil, as well as the environment. And so this has huge implications for the US, other high-income countries, but also very much so for low and middle-income countries, which in face of climate change might be experiencing more drought. And so being able to source a protein that doesn't require much water will be really important. Peanuts, if you think back to the chart or the picture I showed you about the benefits, the health benefits of peanuts, so looking at the fiber content, the fat content, the protein content, the micronutrient content, they can also be beneficial for addressing undernutrition. So when I was showing talking about the global trends of diabetes, I had mentioned this term, the double burden of disease. So for countries in Africa, for example, where diabetes, cardiovascular disease is on the rise, there's also undernutrition, and there's still an uncomfortably high number of children who are suffering from undernutrition and various micronutrient deficiencies. So peanuts can address undernutrition, but it can also address obesity and chronic disease risk. It can address conditions on both ends of the spectrum. They can be grown locally in Africa, for example. And I also wanted to, there's women, I'm still going over there to show the slides. There, you can see the women here are harvesting the peanuts. And that's because typically in Africa, for example, it's the women who are farming, and so trying to promote peanut farming could actually help empower women as well. And also, peanuts are culturally acceptable in the diet of many low-income countries. They're already being consumed, they're acceptable. So it's not like you're trying to encourage some new fancy product. This is already there. So there's a number of benefits. So it can address undernutrition, overnutrition, chronic disease risk, and also address planetary health as well. And so I wanted to say a few words about the Sustainable Development Goals. So in 2015, more than 190 world leaders committed to 17 sustainable development goals to help reduce poverty, fight inequality and justice, and fight climate change. And you can see the 17 goals here, but a number of them relate to nutrition, and a number of them relate to sustainability. And so sort of trying to increase nut consumption, peanut consumption, actually folds very nicely into achieving some of these sustainable development goals, as well as the goals for climate change. And so building on the sustainable development goals, there's another goal, and this is now, it's called the World in 2050. And so this is sort of another goal that was put together by the Sustainable Development Solutions Network, part of the United Nations. And so the goal is by 2050 to provide a global population of nearly 10 billion people a healthy and sustainable diet. And so just to remind everybody what the situation is globally, we have nearly 1 billion undernourished people, and so very few are meeting guidelines for diet quality. About 2 billion people who are obese, and this is growing. We're not really meeting the Paris Climate Agreement to reduce global warming to no more than 2 degrees Celsius, and we're seeing rapid environmental degradation. So those are the reasons why this additional goal beyond the Sustainable Development Goals was initiated. And so just to summarize, animal-based foods, as I showed, such as red and processed meat, are associated with weight gain, increased risk of diabetes, cardiovascular disease, cancer, and death. And these products are less environmentally sustainable. We show that they have higher land use, water use, and greenhouse gas emissions. We also show that there's benefits of plant-based foods such as nuts and peanuts on body weight and risk of diabetes, cardiovascular disease, and death. And these options are more environmentally sustainable. And then we saw that there's benefits of substituting nuts and peanuts for animal products such as red and processed meat on risk of diabetes and cardiovascular disease and death. And by doing this substitution, you can improve health, but you can also improve environmental sustainability. And so finally, consuming peanuts as part of a healthy plant-based diet is a cost-effective, feasible, and sustainable approach for prevention of obesity and related chronic diseases, as well as undernutrition in low and middle-income countries, for example, but also in the US. There's parts of the US that are also suffering from undernutrition. It's not just in low and middle-income countries. And it also has important benefits for planetary health. And so, thank you very much, and I think we have lots of time for questions. Yeah, questions? Yeah?
With the nurse's health study, I used that quite a bit in the research for the fertility book, and I noticed that walnuts recently came out with a study supporting walnut consumption and omega-3s with sperm health. And there's not as much research with male infertility and focusing on how because we know plant-based diet helps with male infertility, but looking specifically at peanuts, is there anything that's in the works similar to a nurse's health study, but with males, and at all with peanuts and more plant-based protein looking at male infertility?
I think that would be a great question for my colleague Jorge. That's not an area that I work in. Jorge Chavarro works in this area, and I mean, that's a good question. I'm not sure if he's working on that. That would be a great thing to be working on. So, yeah.
Is there maybe this is a more appropriate question then, is there a study that's designed for males like the nurses have done? Okay.
The health professionals follow-up study. So it's the cohort of male health professionals, exactly the same. Food frequency every 4 years, diet and lifestyle every 2 years. Yeah.
Thank you.
Sure. Other questions? Yeah.
Yeah. There are already places in Africa that are making a therapeutic food out of peanuts for the undernourished. And we'll talk about that a little bit tomorrow.
Yeah.
And now you said that it works for the overnourished as well. So would it be feasible, and these are very inexpensive foods, would it be feasible to make packets for diabetics as well, or people with pre-diabetes?
Yep. think that would be a helpful option. Yeah, I do.
So in your work where you're comparing the quality of plant-based foods, when you're looking at that data, are you looking at like what percentage of the diet, like what?
Yeah.
So we can kind of look at like numbers on
That's a great question. I didn't get into those details, but yeah, it's a spectrum, so almost like a score. So looking at people who adhere to a plant-based diet more, so it's really, it's a percentage of plant-based foods, percentage of healthy plant-based foods, so it's being looked at that way.
So is it like, I think, did you say something like 80%? Or I mean, can you kind of quantify it a little bit for us, or
In terms of
like what percentage of the diet, or like are showing those numbers?
Yeah, and so it's tough to sort of say like you want to know kind of like what percentage of your diet should be plant-based to give the health benefits. Is that the question?
Well, because you had numbers, I forgot.
Yeah.
You had actual numbers, and I was just wondering what that was based on. Like, what percentage of the diets were healthy plant-based?
This one.
Yeah.
So this is looking. So this is now this or this one.
Yeah.
Yeah. So this is looking at. This is the dose-response relationship. So you can see the serving of the food calories consumed per day on the bottom, on the horizontal axis on the bottom. So 20 servings. So servings of the food calories consumed per day. So 20 servings, you're seeing the benefit. So 20 servings is a little bit extreme. No one's eating 20 servings. So let's look at 5 servings. You're going to see. You're also seeing, or 6 servings. You're seeing about just under a 20% decrease of heart disease from the healthy plant-based foods.
So if they were eating 5 or 6 of what you defined as healthy plant-based foods, and the other foods could have been the not so healthy or whatever, and that we started seeing benefits of that.
Yeah, exactly. So trying to look at, exactly. So as long as you're eating those 5 or 6 of those healthy plant-based foods, it didn't matter if you were eating the red meat, like the other things. It balanced it out. So
And
that's where you see the balance.
And you saw a dose response, so people that did, like, what if 100% of their diet was healthy plant-based? Did you see even more?
Yeah, and so this was looking at it in servings per day, and so so you can see where it comes out if you're saying if you ate 10 servings per day of the plant-based foods, you're almost getting a doubling of the benefit. So that's how. Yep.
That'll be, so you're going to be producing more studies with this,
this
data
so
then.
this is now a new way we've come up with. It was actually the thesis work of a doctoral student in our group. She's working with Frank, and this was her doctoral dissertation work. And so she's looked at diabetes, heart disease, and there's a study that either just came out on weight or is coming out soon on weight change. Yeah, so and then some people are looking at it with cancer outcomes as well. So you'll see probably a number of studies coming out using this approach. Yep.
Did that same study look into, or maybe a different one, to look into like the comparison between lean protein, animal-based lean protein, and
no, it didn't look at. That would be another index to make, but it was really. This was focusing on trying to tease out healthy versus unhealthy plant-based foods and lumping all of the animal foods together. It didn't separate out quality of animal foods.
In the few areas that you chatted about peanut butter, was it based on natural peanut butter or regular, quote unquote, like normal peanut butter, or a combination?
Yeah, it's a combination. The questionnaire doesn't delve that finely into that question. It just has the question of peanut butter. It doesn't talk about brand. It doesn't talk about style of peanut butter. So we were not able to get into that detail. Yep.
I had a similar question to that. Specifically, I know you said the study was done in 2002 with the peanut butter and scope type a lot of added sugar going into these products, would that skew? Would it still have the same plant-forward benefits and the lower risk of type 2 diabetes, or would it kind of now conflict it with the added sugar?
So that's a tough question because we're not able to look at that in our questionnaires because we are not able to tease out what the brands, people, but it seems without teasing that out, just looking at pure consumption of the butter, of for example, peanut butter, we're still seeing a benefit. To answer your question, we would need to do a trial. Yeah, that level of detail, we could do a trial to do that.
Just a comment about that. I'm not sure how specific people are when they answer their food frequency questions, but in America, the standard of identity for peanut butter is at least 90% peanuts at all times. Now, if they're thinking a peanut spread or nut butter is peanut butter, then it might skew the results a little bit, but at least we have that standard of identity to protect us a little bit, and they're at least getting that great nut content, peanut butter from that. In Canada, there is no standard of identity, so I know that peanut butter in Canada is sometimes sweeter, but some you do have some.
Right, and even on, I also say, like Kraft regular peanut butter. Peanuts are the number one, the first ingredient.
But it's usually not 90, but,
Right.
but some are.
And I know that yesterday there were people who seemed to be interested in inflammation, and I didn't actually have a slide for this, but we published a study, I think it was 2 years ago now, that actually looked at nuts and inflammation, inflammatory cytokines, and we looked at it by nut type, and we did find a benefit, so a reduction in inflammation with peanut consumption. And if anyone is interested in that study, I can send it to them. You can reach out to me. I'd be happy to send it. Yep. Sure.
So recently, you read about there's been some, I guess, controversy on the BMI.
Yes.
So can you speak to that? Kind of, what do you think about that? I mean, everything's been based off this BMI for years, and so I was just curious about your thoughts on that.
All right. Well, everyone's comfortable. I can talk about that. Let's go. Yes. Okay. So for BMI, I assume you're talking about the BMI mortality confusion. This is a confusion that cycles back every 6 years, I think.
Okay.
And so basically what the controversy is that some groups believe that being overweight is not related to an increased risk of mortality. It may actually have a little bit of a benefit for mortality. But other groups say, no, being overweight does increase risk for mortality. And so it's like, well, how can there be such polarized opinions on the same question in the scientific community? And there are a number of these types of controversies within the scientific community, and what it comes down to is statistical methods. And so one of the concerns about the study that says being overweight does not increase risk for mortality is confounding by smoking. And so we know that smoking, of course, is linked to greater mortality, right? We know smoking is linked to mortality, but smoking is also linked to having a lower BMI. And so what that can do is kind of obscure the relationship between BMI and mortality if you don't sufficiently adjust for smoking. And so when we looked at this relationship in non-smokers, so just remove this whole issue of smoking altogether, Frank found that the relationship between BMI, or so being overweight, and mortality is there. There is a positive relationship. So So it's possible that the study that there was still some residual confounding by smoking that was sort of confounding the studies that were saying that it's not related. Another issue is your reference group. What's a healthy? So when we do these studies, we always need a reference group. What should be the reference group for BMI? Is it when we talk about the cut points, having a BMI over 30 is obese. Having a BMI over 25 is overweight. And then having a BMI between 25 to 18.5 is healthy weight, and then under that is underweight. Well, if you just combine people who are underweight and a healthy weight together, that can also skew your findings, because people who are underweight could have underlying disease that might be why they're dying sooner. So that's another issue. So these are some issues that have been happening in the analyses that are looking at that relationship. If you set your reference with a healthy BMI, cutting it, between, 23 and 25 or whatever, you can see that, yes, the relationship between BMI and mortality, you do start seeing risks in the overweight category. So that's where that's sort of why that controversy is there. Is that making sense? A couple points about BMI though. It's other controversies about BMI is that it might not always be the best way to capture somebody's weight. It doesn't differentiate lean mass from fat mass. It's not able to do that. So somebody who's a bodybuilder with a lot of lean mass might be heavier, so they're going to have a high BMI. That's sort of, right, so there are those issues where, well, that doesn't mean that person is unhealthy, because their BMI, the high BMI, is being driven by muscle mass. And then for the elderly, so the measurement of BMI includes height. And so for elderly patients who start losing a little bit of height, BMI is not the best measure for weight, for adiposity for that group either. So there's limitations to BMI.
What do you think is a better measure?
For a health outcome, I like waist circumference.
Yeah.
It's a little more challenging, right? You have to know how to do it, but I think that is probably a better marker for like cardiometabolic health.
Right.
Yeah.
Measure just body fat percentages?
Yeah, you can measure body fat, but I think that can also, you can run into logistical challenges with that. A little more time, you need a technician, or so. But yeah, that's another good option.